Thank you so much for having me today. And I'm sorry I can't be there in person. I'm actually presenting at another conference today, but I hope you're all having a great conference. I want to talk to you today about some the updated research that we've got on Charles Bonnet syndrome. So much of this has been done across my previous two centres in Oxford and Cambridge. But for those of you who are not aware of Charles Bonnet syndrome, I thought I would start with this little graphic of what Charles Bonnet syndrome actually is. So this graphic was put together by a patient of mine who is also an artist, and she created this from a description from another patient, and it's a robot that is crossing the road at the same time as a car. Now, the robot is really crisp and clear, but the background is really dull. So that mimics Charles Bonnet syndrome because the hallucination uh, is clear, whereas the normal vision is not necessarily clear. It depends on the disease that the background eye disease. So Charles Bonnet syndrome is the presence of visual hallucinations in response to some kind of vision loss. It doesn't matter what the vision loss is, where along the visual pathway it is occurring. It can be at the level of the eye, at the level of the brain, or anywhere in between. We don't know exactly how many people it occurs in, and I'll talk a bit more about that later. But the way that you know they're not real is this difference in clarity between the hallucination, which are always crystal clear, compared to the actual vision. So the key questions around Charles Bonnet syndrome are the prevalence, how often does it happen? The mechanism, what's actually causing it? And I guess the most important question from many people's perspective is treatment. So what I want to go through today are some myths that have occurred around Charles Bonnet syndrome. So myth number one, CBS only occurs in the elderly. Well, I think this myth has occurred because a lot of the initial studies were done of it in people with macular degeneration, with macular degeneration being one of the most common diseases that cause vision loss in this country and many of the developing countries. And so just by chance, that means that we're going to see naturally a higher prevalence. But actually, we know that's not the case. So I'm going to buff that myth because you can actually have CBS at any age, including children. And a project led by Lee Jones in London developed resources for how to speak about Charles Bonnet syndrome to children, and they developed the Friendly CBS Monster, and there's a whole page on Esme's Umbrella website dedicated to Charles Bonnet in children. So I highly recommend looking out for that. And for the Macular Disease Society, which also serves patients with Stargardt disease and other more juvenile macular dystrophies, that can be highly relevant because those patients can also be affected from an early age, and it's important that they are aware that this can happen to them just as much as people with macular degeneration, and it can be no less scary when you don't understand what's going on. So the next myth is CBS has a low prevalence. Well, we don't know the exact prevalence because it's really hard to do prevalence studies unless you question every single person that comes into a clinic. You're not going to know the exact prevalence. So unless you question literally every person, how can you say exactly how many people currently experience or have experienced CBS at some point along their visual loss journey. And this makes it especially difficult for us to know exactly how many people CBS affects. But current estimates lie anywhere between 30 and 60% in various studies that have been done. So, that's quite high and much higher than many people realize. Of course, one of our key diagnostic criteria is with CBS is that you have insight, so that you realize after it's been explained to you that you can tell that they are not real. They might seem very real, they might look very real, but logically you understand that they are not real. And once that's been explained to you, you do come to realize that, and you don't start believing that they are very real. If you believe the hallucinations are real, then it's clearly not CBS and it's something else, and it needs to be referred for further investigations. So as long as you have a history of vision loss due to any cause, and have insight into the fact that they are not real, which might not be there initially, but once it's been explained is there, then we can be fairly confident it's CBS. And actually, it has quite a high prevalence. So let's bust that myth. Myth number 3, CBS only occurs with significant vision loss. Well, how do you define significant? Because one disease causes loss in visual acuity, so that's how many letters you can read down the chart. Another disease causes loss in visual fields. So you might see perfectly the letter chart because it's straight ahead of you and everything's clear there, but then you lose your visual field. Another disease will cause loss of contrast. So when the black and white letters are clear, but when they start becoming faded, so the grayness, that becomes really difficult to see. Another disease affects colors more. Another disease might affect the speed of your vision or night vision. So there are so many different aspects to vision. How do you define vision loss? And then how do you put a percentage on that? And when you have different aspects of your vision affected in different ways, how do you put it all together? So I always struggle with this significant vision loss because I don't know how to quantify that. Um, but also we published some work where we showed that even if you have one eye completely normal and one eye is lost due to cancer or even temporary disease in there due to retinal detachment, which it then later resolves, you can get Charles Bonnet hallucinations. So that then definitively gets rid of that myth. It shows that's not true. So we've busted that myth that it only occurs with significant vision loss. So what we think is happening there is that, I mean, clearly because the hallucinations are clear, we know that they're coming from the brain. And so you disrupt any input into the brain of the vision, you're setting off this pathway, which then causes hallucinations. Why this happens in some people and not others, we're not really 100% sure. We still need to figure that out. The next myth is CBS only occurs for a short time. So it used to be thought that they resolve within 3 years. And yes, this might be the case for the vast majority of people, but it's not true for everybody. So I've got patients who've had it for 12, 14 years, and it shows no sign of resolving at all. So for some people, they might last a few weeks, few months. And for some people, when you fix the vision problem, you fix the hallucinations. But for other people, the hallucinations will go on for a long, long time. And again, we don't know why that is the case. So I don't think we can make any assumptions or predictions about how they will last for any individual. And there certainly is no rule of thumb about how long they will last. So we can definitely bust that myth. So with CBS, we, as I've mentioned before, we know it's caused by the connections in with the eye and the brain. And I've done a lot of neuroscience work. Now, I've left this slide blank, except for a link to a podcast, because I didn't want people to struggle to see the diagrams. I'm going to talk you through the neuroscience. And hopefully the team can share the link to the podcast with you on the day in the chat. So we've done some neuroscience studies. So one of them was we looked at the MRI of the brains of people who get hallucinations and people with low vision who don't get hallucinations. And we were looking at the neurochemistry of the brain and the wiring of the brain to see if there were any difference in the two groups. Now, unfortunately, because of the pandemic, we weren't able to hire to find as many volunteers as we hoped. So we didn't see any definitive results. We saw some trends, but nothing. So in one way, that's reassuring because it shows there's no big differences between the brains. But also the reason I've got the podcast link there is that this podcast, I talked to one of my former patients about what it's like to participate in studies with no direct benefit and what it's like to go in an MRI scanner. And we talk about the importance of actually taking part in studies and why it's so important to do that, and why he volunteered for several of our studies. So if you're unsure about whether to volunteer for studies and not sure about particular studies, please do have a listen to this one podcast, because we and it's audio only, but we cannot do this work without people coming forward. And without volunteers, we can't make the next lot of discoveries and move our knowledge base forward. So we really do need your help when we do studies. The second study we did, so that first one, the MRI study, was when I was at Oxford University. The second study was when I moved to Cambridge. And what we did was attach electrodes around people's heads, and we collected EEG recordings. So these are brain waves around the head, and we found there were changes in the alpha wave, which is a particular signal associated with vision processing, and the changes occurred over the visual area at the back of the head at the start of the hallucinations. So we recruited people who had frequent hallucinations, and they had several hallucinations during our recording session. And at the start of the hallucination, so we're not sure exactly whether it's just before or bang at the start of the hallucination, but because they were pressing a button at the start of the hallucination, and it takes time to press the button. So, but around that time, we noticed a drop in power of the alpha wave. So clearly there's a change in the brain at that point. So we know that there's definitely a brain signal change in this pilot study, and we're going to try and follow that up with a larger scale study in the future. which is very exciting. So now we know that we can take that and design an education program to educate the healthcare professionals, not just in optometry and optics, but out more widely as well, as many health professionals have never heard of Charles Bonnet syndrome. But now that we've got an actual biomarker in the body, it'll be easier to educate people and say, look, this is a real thing. It's the visual equivalent of phantom limb syndrome or tinnitus. So, we need to be taking this seriously. And when you have someone come in with hallucinations, please can you screen for vision loss and insight, um, as well as all the other things that you're screening for. So for potential treatments, there's again that because we didn't know what was going on before, there were limited options. There have been some drug trials, but they've always shown poor success. Um, but now we know where the brain signal is changing. There might be some future trials that are more targeted, but I'm not sure drugs are necessarily going to be the way to go because they're not going to really be targeted enough. The key thing is knowledge, because with knowledge, with knowing what it is, you can take control of the hallucinations rather than them controlling you. So you can be reassured that no, you're not going crazy. This is perfectly predictable. We know this is happening. This is acceptable. So don't worry about it. And if they are hallucinations that you enjoy, please enjoy them. There's nothing wrong with that, because some people do have pleasant hallucinations. If they are unpleasant hallucinations, that's when we need to start thinking about how to actually manage them. So that's where counseling can potentially come into play, because the hallucinations always relate to previous experience, either conscious or unconscious. So we know that the hallucinations do relate to your actual experiences. You won't have hallucinations that are completely outside of your experiences. So there's a lot of, I frequently get people asking me about, oh, there's lots of reports of Victorian figures in the literature. And I think people just would talk about Victorian figures because they're a popular subject to talk about, but they are not the only thing that people experience. People can experience anything. They can experience flashing lights, lines, they can experience trees, robots, as shown. They can experience characters from books, all sorts of things. But if it's something, so people will experience completely things that are within their scope of experience. So people in India, Africa, for example, will experience completely different things. They're not going to see English Victorian figures because that's not something that is part of their experience. So in the brain, one of the reasons our vision is so fast is in the brain, you've got memory modifying what you're seeing. And so the memory is also playing a role in those hallucinations. Then you've got frequent blinking. That's a mechanism for helping with for some people, not everybody. Some people find it easier to just close their eyes and rest. Some people find ignoring their hallucinations are super helpful, whereas other people find actually interacting with their hallucination makes them go away. So you'll notice all of these things relate to taking control and having the power of your hallucinations. So as I said before, it's all about it's all about you controlling the hallucinations, not having the hallucinations control you. So it's taking the power back. And then there is some work that's been done with transcorneal electrical stimulation. So this was work done in Parkinson's hallucination, which are quite similar to CBS hallucinations, where they apply direct current to the visual area, and that can be shown to be quite effective. In a very small pilot study in over a very short term in dealing with the hallucinations. So, but obviously that needs a lot more evidence because it's very early days in the trial, and because it's way more invasive than the other treatments. It would probably be a last resort for the really troublesome and distressing hallucinations rather than as a first-line therapy. In terms of ongoing studies, at the moment, the one that is ongoing at the moment is a study from Cardiff University, where we're trying to see if there's any way of predicting who will get hallucinations versus who won't. So it's a study that can be done. So we need everybody, anyone with low vision, whether you get hallucinations or don't, whether you experience CBS or don't, to complete this questionnaire. So it's one you can do from your sofa. So please do log on to this link and complete the questionnaire. It has been set up in a accessible format, and we would be really, really grateful for your participation. Thank you very much for your attention, and apologies again that I can't be there with you.
Thank you so much, Jasleen. That was such an interesting talk, and it really covered many different aspects of what we get asked about when people talk to us about CBS. So as you said, you're not able to join us on the day, so we've pre-recorded this Q&A with some of the common questions we get asked about Charles Bonnet syndrome. So one of the main questions we get asked is kind of, what are the risk factors for developing CBS? Do we know why some people develop it and other people don't?
No, I mean, the risk factors are vision loss. Other than that, at the moment, the research is turning all that we thought were risk factors on its head.
Really?
So it used to be thought age was a risk factor. As I've shown, that's not the case. It used to be thought degree of vision loss was a risk factor. As I've shown, that's not the case. So no, I can't say there are any other risk factors. So that's partly why we're doing the study with Cardiff, to try and understand if there are any other risk factors. One of the things we think it might be is that how visual a person you are. So if I say to you, think of an apple. Some people have a really rich visual mind. Some people can't imagine an apple because they just don't have a visual mind. Some people just visualize a basic apple, and some people think of a really elaborate apple with a shadow and like very elaborate coloring and a stalk and a leaf. And so we naturally have different levels of visualization. And that might be a determining factor in who goes on to develop CBS and who doesn't.
Oh, that's really interesting. And hopefully the survey will be able to get some really good insights into that. So in your talk, you talked about constant visual hallucinations, or kind of hallucinations that lasting for a number of years or months. Are hallucinations always kind of small episodes, or can they be constant throughout the day?
it's very variable among different people. So I've had patients where they are almost constant for a period and then they will become less so over time, and then they might have periods where they increase. So we know stress and isolation causes an increase in hallucinations. So again, Lee Jones did some work through the pandemic where they showed that hallucinations increased
Wow.
during the pandemic because of the isolation, the social isolation. So it really does depend on what's going on around you at that time as well. They probably increase in winter because low light levels increase hallucinations for many people. Not everybody, but for many people. So yeah, it depends. It a lot of my answers are going to be it depends.
I suppose that makes it very interesting to study because there is so much variation and everyone does experience it so differently.
Yeah, and also there's just so much we don't know because
Mm.
CBS has been so understudied for so long. I think from when I studied 20 plus years ago, not much work has been done on it until recently.
Mm. Yeah, that was something I was going to ask is um, how well known and discussed is Charles Bonnet syndrome? We often
Not,
hear people
no.
know that they don't realize they've got it until
Yeah.
they hear about it from the Macular Society or from other
Yeah, I mean,
bodies.
I was fascinated by CBS when I learned about it during my undergraduate, and I started working in low vision clinics as soon as I qualified, and I used to ask every single patient that came into my clinics,
Mm.
"Do you experience these funny visions that you know aren't really there?" But I don't know that many practitioners do. So we're trying very hard to raise awareness about this and encourage more people to do this. And that's partly why I'm speaking at so many conferences at the moment, especially now I've got the neuroscience to back it up that, this is very much real.
Mm.
So yeah, so I've been talking a lot about this worldwide to try and raise the awareness and encourage as many people as possible to try and screen every single patient and arm them with the knowledge because, as I said, knowledge is the best line of treatment, both preventative and actual treatment that we've got.
Yes, no, we hear so often people are so reassured once they know that these
Yeah.
hallucinations are because of their vision and not because of anything else. So just that knowledge that it's because you have macular disease or because you've lost vision, that's why you're
Yeah.
experiencing the hallucinations can really help so many people. Um, so I think you did touch on this before, but how can people be sure that a hallucination they're experiencing or something they're seeing is because of Charles Bonnet syndrome?
Speak to your healthcare professional. That's the best way. So speak to your optometrist or ophthalmologist, and they'll be able to advise you.
Okay. Yeah, so if someone's seeing something, yes, it's really important. Yeah, no, I agree. Um, and we did mention about what people can do to get rid of hallucinations. Do we know anything that can stop hallucinations happening at the beginning?
No, unfortunately, we don't at the moment. So the tricks I've advised you have part come from research, part from experiences that patients have shared with me over the years. And I guess just trying those out and seeing what works for you. And as I said, if you have pleasant ones, feel free to enjoy them. There's absolutely nothing wrong with that.
Yes, no, we do hear that, especially because, as you said, the hallucinations can be nice and crisp and vivid compared to sometimes the rest of the site that, and if they can
Yeah,
be quite funny or or pretty, then there's no
Yeah,
reason not to enjoy them while they last.
exactly. I mean, I had a patient who would have a full um, garden of roses.
Wow.
Her hallucination was a full garden of roses, and she loved it. So why not enjoy that? You don't have to do the hard work of gardening, and you get the the reward. Why not enjoy that?
Mm. And I think so oftentimes when we hear about hallucinations, we hear about the uncomfortable ones or the scary ones. So knowing that you can have nice, pretty, joyful hallucinations is really good to kind of share the both sides, I suppose.
Absolutely.
Okay, I think that's all the questions I've got, but thank you so much for your talk and for answering some of these questions. And I'm
My
sure
pleasure.
that all of the audience will really appreciate this. Thank you.
My pleasure. Thank you.